Hello, I'm Lauren McCafferty, and I'm an ultrasound fellow at University Hospital's Cleveland Medical Center. As part of my series on point of care ultrasound to augment landmark based procedures, I'll be talking about using ultrasound to confirm central line placement. The main goal of confirming central line placement is to rule out line malposition and pneumothorax. The current standard of practice is to obtain a post procedure chest x ray, but is this really necessary? There's a growing body of evidence that is supporting the use of ultrasound, so why not use that instead? This was a systematic review and meta-analysis of 15 emergency medicine and critical care studies, including over 1,500 central line placements confirmed using ultrasound. They found an overall sensitivity of 82% and a specificity of 98%, with a positive likelihood ratio of 31 in identifying malposition. Similar to prior evidence, they also found that ultrasound was significantly more sensitive than chest x-ray for evaluating for pneumothorax. A clear advantage of ultrasound is that it can give immediate feedback. You can confirm the line before you even leave the patient's bedside, and you don't have to wait for chest x-ray, which almost always takes at least some amount of time. This meta-analysis quantitatively evaluated how time-saving ultrasound can be, and they found that that ultrasound took about 5.6 minutes compared to nearly 64 minutes for chest x-ray. And when you factor in the time it takes for radiology to interpret the x-ray, it was over double that. So overall, ultrasound saved nearly an hour, which seems like an eternity before you can safely use the line. To evaluate for malposition of the line, one of the first things you can do is confirm that you're in the vein when you're actually placing the line. So even if you're using dynamic ultrasound guidance and you're pretty sure you saw your needle go into the vein, you should still confirm that the guide wire is in the vein before you dilate. This is what it looks like in a short axis view, where you can only see the part of the guide wire directly beneath the probe. It shows up as the bright white structure within the lumen of the vein. And on the right, this is the long axis view, and you can actually see the entire guide wire coming down through the soft tissue and curving in the lumen of the vein. So I think this is a little bit better view, and for that reason, I like the long axis view better, but either one works. And even if you're doing a landmark-based subclavian, it's still a good idea to confirm guide wire placement with ultrasound, just to ensure that you are in the vein, especially since the subclavian vessels are difficult to compress. Another way to evaluate for malposition is to look at the nearby vessels. So depending on which vessel you chose and which side, you're going to consider looking at the ipsilateral IJ or subclavian, as well as the contralateral vessels. This will help ensure that the wire didn't go in the wrong direction, which can certainly happen. Next, you're going to look at the heart, particularly obtaining a view in which you can adequately visualize the right-sided chambers. So this would be your subxiphoid view or your apical four-chamber view. You'll look at the right atrium and even the ventricle to see if the catheter was maybe advanced a little too far. If you do see the catheter, you know that you're in the right vein, and you just need to retract the catheter until the tip sits in the cavoatrial junction. If you didn't see the catheter and still need to confirm appropriate placement, you can rapidly push a saline flush and look for turbulent flow in the right heart, as demonstrated here. If this is present almost immediately after you push the saline, it's safe to assume that you're in the appropriate vein. This was a prospective study of 78 patients looking specifically at the use of saline injection to confirm central line placement. Similar to the meta-analysis that I talked about earlier, they found a specificity of 100%. Here they found a sensitivity that was slightly higher at 87%. They also found that the median time to POCUS completion was about 50% less compared to that of the chest x-ray group. So less difference than in the meta-analysis, but still significant. Next, you're going to evaluate for pneumothorax, which you do by looking for lung sliding at the pleural line. Remember that you want to have 2 ribs in view, one on each side, to ensure that this truly is the pleural line that you're looking at and not something else. In this clip, you can see good lung sliding movement at the pleural line, as well as a few small comet tail artifacts. This tells you that the visceral and parietal pleura are well approximated, and you can effectively rule out a pneumothorax. If the pleural line looks something like this, where it's static, you don't really see sliding, there's no comet tail artifacts, you should be concerned about a pneumothorax, particularly in the setting of a recent central line placed on this side. However, you have to remember that this is not the most specific, as other processes can mimic this appearance of the lung. A lung point, however, is specific. This is the point at which the parietal and visceral pleura start to separate when there's a pneumothorax. So you'll see normal lung with sliding next to abnormal lung without lung sliding. And this is nearly 100% specific for a pneumothorax. Some general take-home points. Remember that your overall goals in confirming central line placement are to rule out malposition and pneumothorax. Evaluate for malposition by ensuring that your guide wire is going into a vein as you're doing the procedure, and you want to do this before you dilate. Look at the nearby vasculature with your ultrasound probe to make sure that the line isn't going somewhere that it shouldn't, such as into the opposite side of the chest or up one of the IJs toward the brain. Look at the heart to make sure the line didn't get advanced too far and the tip is now in the right atrium or ventricle. And also, you can rapidly administer a saline flush and look at the right side of the heart for turbulent flow. For pneumothorax, you'll look at the pleural line and look for the presence of lung sliding. If you see lung sliding, you can essentially rule out pneumothorax. Also, if you see B lines or comet tail artifacts, this also rules out pneumothorax as well. The bottom line is that ultrasound rivals the current standard chest x-ray in confirming central line placement. It's fairly good at evaluating for malposition and is even better than chest x-ray in ruling out pneumothorax. Another key advantage of ultrasound is that it can much more rapidly give you the answers you need and thus allow for quicker use of the line. If you have any questions, please feel free to contact me. Thank you.